take-home message that I got from this is that there seems to be about a 30% prevalence of non-adherence in apparent treatment-resistant hypertension.
So, Gary, one of the things that I found really enlightening over time is actually going into people's homes. So, patient I've known for years. She's always seemed to be very adherent to me. I go because she has an acute illness, and she says, "Oh, could you grab me some of blah, blah, blah? It's over there in the cabinet." I open it up. She has bottles full of medications. Bottles. They're like in a huge box. So I'm not shocked at all that people taking 3 or more medications just for their hypertension were having problems with compliance.
So as a corollary to that, when I was first starting out practicing, probably about 20 years ago, one of my patients lived in the neighborhood that I live in. So I walked over to his house one day, real similar thing, blood pressure issue, et cetera, et cetera. He pointed me to the drawer where all of his medications were. And like you, he probably had 30 or 40 different bottles in there. I pulled them out and the name Duffy was on it. And I said, Jim, who's Duffy? That's my dog. So he had his veterinary prescriptions mixed in with his own. So point well taken, Heather.
Nice.
Well, I do want to point out the heterogeneity was huge. I have never seen a number this big. 99.5%. I mean, they're not comparing apples to apples at this point. They're comparing apples to bacon. Oh, bacon. But really, I mean, these are separate types of studies that they really should be not combining. I was really impressed. I've never seen a I-squared score so high. Wow.
And we know you live for I-squared scores.
Oh, I do. I do. All right. So number 3, we're all aware that the statins are often not well tolerated. So we've got a systematic review and meta-analysis trying to answer the question, if taking the medication every other day works with less side effects.
So this was an article in Cardiovascular Drugs and Therapeutics, 2017, August, by Awad et al. And the title of the article was Lipid and Blood Pressure, a Meta-Analysis Collaboration, so they had an acronym for that, Efficacy and Safety of Alternate Day versus Daily Dosing of Statins, Systematic Review and Meta-Analysis. And there was a fair number of conflict of interest declarations, about 25% of one column in small font. So I just wanted to make that clear. So statins, of course, are widely prescribed in the world. And they're highly effective, not only in terms of decreasing cholesterol, but also in terms of certain clinical outcomes as well. They did have a statistic in here, which I actually hadn't heard about before, but it makes a certain amount of intuitive sense. They said among survivors of myocardial infarction who experience statin intolerance, the risk of a recurrent event is 50% higher compared to those who are adherent to statin therapy. So non-adherence, adherence, if you have already had an event, certainly your risk of recurrent event was higher. And it makes a certain amount of intuitive sense. So they identified the presence of several smaller studies looking at alternate day dosing for patients who experience adverse side effects compared to daily dosing, And what they found was 13 studies, only about 1,000 patients. So a lot of smaller studies that they lumped together in terms of this meta-analysis and systematic review. And they were looking for the efficacy. Now, they were looking for biochemical efficacy. They were looking for what happened between alternate day, daily dosing, to the lipid profiles, and was there any difference in safety profiles? They didn't look at clinical outcomes, such as fewer event rates and the like. So what did they find? For atorvastatin and rosuvastatin, there's no statistically significant difference in LDL cholesterol and triglycerides between alternate day and daily dosing. They did note that total cholesterol, there was a delta between alternate day and daily dosing for atorvastatin and rosuvastatin of about 12 to 15 milligrams per deciliter. I'm not sure how clinically significant that is. But the important one, which is LDL, they said that they couldn't find that there was a difference between alternate day and daily, given the limitations of the study. They also noted that fluvastatin and pravastatin, some of the older statins, there was no difference noted between alternate day and daily use of those statins. And there was no difference in adherence, and for the most part, they said there was no difference in tolerability. Obviously, limitations, small size of the study, generally short duration follow-up, a lot of heterogeneity between some of the results, and there is no standard assessment for what is actually defined as muscle-associated statin symptoms. So this is, obviously, I think, from my perspective, an alternative. If a patient's having SAMS, statin-associated muscle symptoms, why not consider going to an alternative scheme or alternative regimen of statin use?
Where to start? Okay, well, you did identify the conflicts of interest, and that's, as soon as I see all that little print going on about conflicts of interest, this happens. That's my skeptical radar, by the way, people.
See, I have a little asterisk with that. I don't actually have a warning signal going off my brain. But I got a little asterisk.
And then I looked at their introductory statement about statins playing a key role in primary prevention of cardiovascular disease is now well established. I'm not so sure. You go to the site, thennt.com, and you look up statins for people with low risk of cardiovascular disease. And if they've been taking it for 5 years to prevent heart disease, it actually gives a red recommendation, as in don't do. And then if you looked at looking to prevent heart disease on those without known heart disease, so again, primary prevention, it also gives a red flag, as in the harms outweigh the benefit. So I don't think the case is that convincing for primary prevention. For secondary prevention, okay. But, you identified the real problem. They looked at all these little studies that had surrogate markers. I mean, what was their cholesterol profile? And if you could read my shirt, this is what I want to know.
But did you die?
That's right. Yeah. Did they die? They didn't even talk about MACE events, major adverse coronary events. I think that's what patients really care about. I mean, I know we sort of hammer into them, what's your LDL, what's your HDL, what's your triglyceride level? But really, I mean, having some hard cardiac endpoints, I want to know, geez, did I get a heart attack? Did I end up on the wrong side of the grass because of this?
Yeah, no, I agree. But I think there is a caveat to what you're saying, and that is primary prevention. The power is going to be driven by the baseline risk. Yes, so you did appropriately essentially say low, baseline risk.
Low risk or without prior heart disease. But
even the AHA, ACC, which are generally prone to be pretty aggressive with the recommendations, basically say, anybody essentially less than a 7.5% 10-year risk should not be on a statin, if they're for primary prevention. So I do think there's some nuance to your comment about primary prevention.
Like in all things, it all depends.
It all depends. Who said that before? That sounds very familiar.
Stop stealing my line.
Okay, well, you go ahead, Heather. You got anything else? Come on, you got a backup. You got a plan B. You got a second line. Grow up.
Is this the outcome that we care about?
These aren't the outcomes you were looking for. Oh, am I getting a Star Wars-y on you? These aren't the outcomes you're looking for. All right. So abstract number 4, this is looking at special diets to help prevent cognitive declines. No, that's you?
It's me.
Okay. Well, abstract number 4 is you, Heather. Obviously, I'm having some cognitive decline. Now, this study was specifically looking at prodromal Alzheimer's patients. I guess I only have part-timers. I'm forgetting things some of the time that you've got this one.
No, we're just tricky and we switch something on you without telling you.
I think you do that on purpose. Let's see if we can throw Ken off. Oh, but I just rolled with it, baby. I've got the part-timers.
Nice. So this is an article from Soininen et al. In Lancet Neurology, 24-month intervention with a specific multinutrient in people with prodromal Alzheimer's disease, lipida diet. I have no idea if that's how they say it. A randomized double-blind controlled trial. And this came out in December of 2017. So the bottom line, don't expect to drink a little fancy drink and not get Alzheimer's.
Aww. Really? You mean life is not that easy?
No. So they came up with this thing that they had some basic science evidence to, this whole concoction that might help protect nerve cells, blah, blah, blah. They did a pretty good job of randomizing people, following them over at the time, all of this kind of thing. And there was no difference. And they said, well, it's because fewer people developed Alzheimer's than we expected. And so it just wasn't powered well enough. Maybe. But don't expect to protect your brain by drinking a little teeny 125 milliliter thing daily.
But the substances were neuroprotective.
In a lab. If you stay in the lab, Gary, and drink that, maybe you won't get Alzheimer's.
There's no magic bullet. just for our listeners, if you have any interest in this whole issue of dementia, very quickly, the Annals of Internal Medicine published 4 companion papers from the Minnesota Evidence-Based Center. I'm sure I'm not saying that correctly, where they looked at exercise and its effect on dementia, dietary supplements and its effect on dementia, mind games, those things you can do online, et cetera, and its effect on dementia, as well as prescribed medications. I think they looked at 46 different prescribed medications. And their summary comment for all of those was the evidence for effectiveness was nowhere near the amount of evidence that is required for a U.S. Preventive Services Task Force recommendation, meaning that there's no magic bullet out there. And the ACC, and not the ACC, but the American Stroke Association and Lancet last year published huge articles, which are great, looking at this whole idea essentially of dementia being a life course illness. It's really starting back in middle age and even earlier. And by the time people become symptomatic, there's no one magic bullet that's really going to turn this thing around. So anyways, this does not surprise me.
And Gary, that's why I was trying to play mind games with Ken.
That's what I thought. I thought, you were just trying to improve my cognition, even though you don't have any science behind it. Oy vey. Okay, so abstract number 5, though. If I can't get smarter or, prevent Alzheimer's disease from a little bottle of, magic, how about if I just stop taking my PPI? Will that help? Because can PPIs be associated with mild cognitive impairment?
So this is an article by Goldstein et al. F. Goldstein et al.
Oh, easy there. We don't want to lose our iTunes rating.
Okay, proton pump inhibitors and risk of mild cognitive impairment and dementia, published in the American Journal of the American Geriatric Society in 2017 in September. The authors had no conflict of interest. And before a couple of days ago when I was reading this article and preparing for this, I went to Google and I typed in proton pump inhibitors and dementia. And you can imagine that there was
how many legal firms came up?
What's that?
I was going to say, how many legal firms came up? Have you been injured by...
They weren't on the front page, but there's a lot of concern about this. So I thought this was a fantastic study, really. It's one of the best I think we're going to see with regards to this question of whether or not proton pump inhibitors are associated with dementia. And by the way, proton pump inhibitors in the last 4 or 5 years have really come out being associated with almost every condition. I mean, not a month or two goes by where all of a sudden there's a new study out there suggesting it's associated with some adverse event. So in this particular study, they wanted to ask the question, does this have any effect on cognition and dementia, specifically Alzheimer's disease? Observational longitudinal study. Almost 11,000 participants, average age of 73. 60% female, 12% African American, baseline normal cognition or mild cognitive impairment at baseline, so they weren't severely affected. They were actually seen 2 to 6 times per year over a 10-year period of time. A lot of data points, 30, if I'm doing my math correctly, up to perhaps even 60 data points. During these visits, they basically were assessed for cognitive impairment, dementia. And during the visits, they also collected a lot of data, one of which was what medications are you currently using, et cetera, et cetera. So at the end of the study, they divided them into 3 groups. Those patients who were always reported being on a PPI, those patients who intermittently reported being on a PPI, and those who reported never being on a PPI during this 10-year plus follow-up. Then they asked the question, in these 3 groups, what was the prevalence of dementia or mild cognitive impairment? Continuous use versus never use, the hazard ratio for development of dementia or mild cognitive impairment was about 0.8, suggesting a 20% protective effect of the PPI for the development of MCI or dementia. Those who were using it intermittently also had roughly about a 20% protective effect for MCI or Alzheimer's disease. So it seemed to be associated with a lower risk of decline of cognitive function over this period of time, both when they did the retrospective analysis of those with normal baseline cognition and those who had mild cognitive impairment at baseline. And probably the biggest problem, if you will, with this particular one, of course, is observational study, but also it's about self-report. There's self-reported medication use and the like. But be that as it may, I don't know how you could design a study any better than this to actually answer the question in an efficient way.
So there have been some studies looking at PPI use in Sweden and other countries where they can actually at least get the refill data and track that. And we've reviewed some of that before. So that would be, I think, really interesting to see as well. The other thing that I didn't bring up when we were talking about the lipid diet is this whole idea of progression of mild cognitive impairment to dementia. And Gary, I remember a few months ago, you had actually talked about this, that a lot of these folks actually get better. And it's not necessarily a progressive disease.
Correct.
And so it's hard to really sort out what all of those effects are as well. So that's just one of the things that I always worry about when I'm reading studies like this.
Yeah, and that's a point well taken, because I think the summary statistic from that is when they did a meta-analysis of the risk of progression from MCI to, because we used to think about MCI as being inexorably linked to the development of dementia. The authors were very clear, 20 to 30% of the time, people with MCI revert back to normal cognition. So it's not necessarily an inexorable march toward dementia.
There's hope for me, but I still don't know. Can I be taking a PPI or not? What's your recommendation?
Well, it depends. Are you having any symptoms, Ken?
No, I have no symptoms.
Okay,
Are you talking about cognitive decline or GI symptoms?
Mostly GI.
Okay.
Or are you at high risk for ulcers and you need chemoprophylaxis?
I think I might be getting at higher risk just because I have to be taking so much more NSAIDs these days because my old knees are getting out on me lately. So maybe I am getting at risk. All right, well, let's move on to number 6. And this is going to be the interview. So Gary, you've got a whole long interview on this. It's up to you to summarize this study looking for an association of cognitive decline connected with atrial fibrillation.
I can summarize it very quickly. First of all, there was a large study in England called the Whitehall study, prospectively collected data over 25 to 30 years. They asked the question, independent of stroke, is atrial fibrillation a risk for the development of dementia? As it turns out, independent of the presence of stroke, there's an 80% higher risk of dementia in those with AFib versus those without AFib. Now, they didn't look at treatment. They weren't able to pull out the issue of, were they anticoagulated or not. But that's the summary statistic here. It wasn't quite as potent when they looked at mild cognitive deficit. But this is a very interesting area. I do some CME work as well. We had a whole section here on dementia, and the connection between AFib and dementia is really intriguing. And there's at least some observational data to suggest that dementia in AFib patients can actually be, the risk can be decreased, of course, by appropriately treating them, which with medications that you would treat them with for anyway, such as oral anticoagulants. But instead of going through the entire thing, because we went through it in great detail in the interview, that's the summary statistic. AFib, an independent risk factor for the development of dementia or cognitive decline.
Did you ask them if atrial fib just might be a surrogate marker for frailty?
Well, they did look at, let me pull this out here. They looked at socioeconomic status, age, ethnicity, education, health behaviors, and multiple chronic illnesses. So the methodology, included a multivariate analysis, including those. I'm not sure. I don't see frailty in there, but maybe multiple. I'm just wondering
diseases. If it's like a subtle, that like that's the granular detail that if you have atrial fibrillation, that just other things aren't going well that may not be picked up on some of these other indicators, and it's a measurement of just being less healthy.
So Ken, I just want to check in. Is this a dig on Gary for having an 8-hour run of AFib?
No, the dig was about checking. The whole dig was him being drinking too much. I'm sorry if that wasn't obvious enough, but I was just trying to get the holiday heart, and he got it like that. He understood it. Yeah. No, so sorry if you aren't keeping up with us there, Heather. It was totally overt. Okay, so abstract number 7. This is a systematic review, but no meta-analysis, to report on watchful waiting versus pharmacological therapy for subclinical to mild to moderate depression.
Well, I'm on a real roll here, aren't I? So this is why we made that change early on, because we knew this would be a problem with me dominating the early part of this month. So anyways, this is interesting. It was Iglesias Gonzalez in Family Practice, November of 2017. The title of the article is Comparing Watchful Waiting with Antidepressants for the Management of Subclinical Depression Symptoms to Mild to Moderate Depression in Primary Care Systematic Review. So basically subclinical depression or mild to moderate depression. How do we manage that? I mean, can primary care docs manage this? And is there any difference between watchful waiting and early medication use? So the authors initially identified almost 1,600 potential articles. This is Ken. Maybe you can help me out here.
Sure. Okay. Here's the thing.
It just seems like there's.
We reviewed the world literature. We found 1.3 million articles. We excluded 1.3 million articles, except for these two. And we got it down to a summary statistic with a 95% confidence interval with a p-value going 0.00003. It's like, no.
So Ken, I couldn't have said it any better. You do not have dementia. That was really well done. But this is the norm. They find a million articles. They boil it down in this situation to 3 articles, and so they excluded them for all kinds of potential reasons. But I think the primary issue here they didn't want to have contamination of in the primary care setting with people being referred off to psychologists or being referred off to psychiatrists, et cetera, et cetera. Can family or generalists such as ourselves basically manage these patients with either subclinical or mild to moderate depression just by watchful waiting versus initially putting them on an SSRI? So long story short, there was 3 articles. What they found here is about 350 or so patients in the studies, relatively young, 35 to 45. And when they were randomized between watchful waiting and antidepressant therapy and followed for 6 to 12 months, they couldn't find any difference between the 2 groups. Basically, early initiation of SSRI had no additional benefit to just watchful waiting over this period of time. And I think appropriately what the authors concluded was, there's a dearth of studies that were, if you want to look at their exclusion or inclusion criteria in primary care settings, where of course most of these patients are taken care of. So I think what this points to more is the lack of very primary care centric studies on a very common problem where most of these patients are being seen and managed anyway.
I think that it's also interesting that at least in the US, we have data that we're both overusing antidepressants and undertreating depression. Ugh. I can't do that right. Thanks, Ken. He'll fill in for me. But so I think we have difficulty in identifying the people who need the medications most and then actually delivering it to them. And we know that so symptoms do not a disease make. A. And B, we know that mild to moderate depression usually has a self-limited course, and you can expect that the vast majority of people are going to get better at a year. So this was not surprising to me at all.
Good. Yeah.
I'm going to say this with a smile on my face, but I was miffed in 2 ways with this study. So here I am smiling away about how I was miffed. Myth number 1 was they say that there was a tendency for pills to work better. Oh, you know what? I speak stats, so let me translate that for you. It means no statistical superiority over watchful waiting. I'd be very surprised if the study had showed a tendency of superiority to watchful waiting, that they would have highlighted that in their results. So I was like, really? You know what? A tendency does not a statistical significance make. And then myth number 2 is, where was the evidence on harm and adverse events? How am I supposed to decide whether or not a therapy is indicated or will be of benefit for the patients I'm trying to treat if they don't even mention harm? And not only did they not mention it, they didn't even collect it. So if you're not even collecting information on harm, how am I supposed to make a balanced, informed decision or advice to the patients that we're trying to treat? So myth number 1, myth number 2 with a smile on my face.
Did your COI alarm go off?
That went off. Oh, sorry. Here we go. Yeah, when they said there's a tendency for pills to work better. Okay, not buying it.
So mine's Ayuga.
Ooga. I like it. All right, so we're going to move on to abstract number 9 now. We have a wee little aspirin. A wee little therapy. Yes, we'll see if it helps with venous leg ulcerations. I have no idea why I'm pulling out the Scottish accent. I just looked at it and said, oh, this one's from New Zealand. So it was a misplaced accent.
That's a lot of UK expats, I think, in New Zealand. So.
Okay. Oh, so you're going to give me that one. Excellent.
Yes. So Jewel or Hull, I'm not sure how they pronounce it, et al. From New Zealand published this article in BMJ back in November of 2017. Low-dose aspirin, 150 milligrams, versus adjuvant treatment for venous leg ulceration, a pragmatic, randomized, double-blind, placebo-controlled trial, or aspirin for VLU. Not as catchy as some of the other trials out there, but that's okay. So they desperately tried to recruit patients who met both their inclusion and exclusion criteria and really, really struggled to do so. They ended up with 251 of almost 1,600 patients that they were able to recruit in this. They excluded pregnant women, people who are vasculopaths. Okay, so that's going to be most people with venous ulcers, right? Or who are otherwise on aspirin or anticoagulants. Once they got it down to this 250 people, they found that there was absolutely no benefit in the 150 milligrams of aspirin. There have been some other studies that reported that there were some benefits. They used a higher dose, whether it was that, whether it was how stringent they were being in their exclusion criteria versus the other studies. But if you've got somebody who doesn't have another indication for aspirin, who has a venous stasis ulcer, do not give them aspirin to help their leg heal.
Well, they also reported no difference in adverse events, and I found that hard to believe because, you take this population and you put them on aspirin, I think that they already have a pre-test probability of falling, and there is some weak evidence that those who fall and hit their head on aspirin are at greater risk than those who fall and hit their head on Coumadin for intracranial hemorrhage. So the study probably just wasn't big enough, and they maybe not looked carefully enough to find the harm associated with, because 150 milligrams on aspirin every day, if you're not got any benefit, I bet you there's harm in it.
Or they're not taking it.
Or they're not taking it. Yeah, back to our adherence thing for hypertension. All right, abstract number 10 here. This is looking at low-carb diet for type 2 diabetes.
Heather, why don't you take a break? I'll take the next three, okay? So I've got the next three, and they're all related to diabetes. This is the title of this article is Efficacy of Low Carbohydrate Diet for Type 2 Diabetes Mellitus Management. Again, one of these systematic reviews and meta-analyses of randomized controlled trials in diabetes research and clinical practice in September of 2017 by Meng, M-E-N-G et al. No conflict of interest were identified by these authors. They actually set out to perform, as I mentioned, a systematic review and meta-analysis of RCTs to evaluate low carbohydrate diet. Now, how do they define that? It had to be less than 130 grams per day or less than 26% of daily energy intake from carbohydrates. Looking at 3 or 4 outcomes. They looked at weight loss. Was it more effective versus an alternative diet? Blood glucose and blood, including fasting blood glucose and A1C and blood lipid concentrations solely in diabetic patients. Like we've said previously, that thousands of potential articles would boil down into 9 that they used for their meta-analysis. Of the 9 studies, 5 were actually deemed to be of high quality based upon the JADAD score, basically, 4 of which were moderate or low quality. Of these 9 studies, there were a total of 700 participants, a lot of smaller studies lumped together. I wrote down the average age was between 24 and 174. I'm thinking that 174 is not accurate, so I think it was 24 and 74. So what did they find? Early on, the low carbohydrate diets were more effective for weight loss for interventions lasting less than 12 months. If they took the intervention beyond 12 months and measured the effect of, say, a low-fat diet versus a low-carbohydrate diet, no difference in weight loss in these diabetics. What they did find was that the A1C was significantly decreased in the low-carbohydrate diet group versus the low-fat diet group. And I couldn't quite figure out what the delta was between the two groups because they used different types of statistics, but they called it significantly decreased. They also noted that the triglycerides were decreased and HDL was increased on the low carbohydrate diet, but no difference in the LDL or the total cholesterol. So long story short, they do suggest a potential benefit of low carbohydrate diet for glucose control in diabetic patients with type 2 diabetes, has almost no effect on long-term weight loss in this group of patients.
You're not allowed to say anything, Heather, for the next 3 abstracts. You know that, right? He already said that when he introduced this one.
I gave her permission.
No. Oh, yeah, she's sitting there eating and drinking. Yeah. All right, but I'll say something. This study came out of China, And it just triggered a memory. I read a paper recently by my EBM guru, John Ioannidis, and I'm sure I'm pronouncing his name wrong, Ioannidis. But he said that this paper came out that he looked at systematic reviews and meta-analyses have increased close to 3,000%, with 1/3 of them coming out of China. And most of these systematic reviews and meta-analyses are redundant and misleading. So I'd encourage people to pull that paper. But they're just cranking these things out like commodities now. And they search the world's literature and come up with 5 papers.
Interesting. What do you make of that?
I think it's their rise in China to be an intellectual powerhouse as well, and the meta-analysis is considered at the top of the EBM pyramid of hierarchy of publications, whereas I don't necessarily agree with that pyramid. But it's much easier to do a systematic review and meta-analysis than it is to actually do a large-scale, multi-center, randomized clinical control trial. All you have to do is get a really good research librarian and then start mashing up the data. And so this is something that pretty much anybody can do. And what they're doing is, I think that they're really cranking these out like commodities, and these universities are being you use these for promotion, and so that they can publish these, use them for promotions. The number of academic institutions in China is growing significantly, and so I think there's a huge push now to be published. And so if you look at a lot of these systematic reviews, you look for them, and they're coming out of China.
Interesting. I'm not sure I've ever actually heard that. So I learned something, Ken. Thanks.
Oh, I will flip you the paper after this, because I follow John Ioannidis. He's just such a rock star when it comes to the critically appraising the literature. But you've got to get into your second out of this trifecta, these 3 studies.
I do, actually. So the reason I chose these next 2 articles is because the number of medications we currently have in order to manage type 2 diabetes is exploding. Classes of medications, and within each class, of course, there's multiple different types of medications. So I've become a little more interested over the last couple of years in what's the role of some of these medications. I'm not sure abstract 11, which I'm going to go over, is really necessarily extremely strong. Like, we can buffet that with what the American Diabetic Association is recommending at this point for second-line agents and the like. But abstracts 11 and 12 really look at the combination of metformin plus a second agent. So abstract 11 by Moghlouglu et al. Is entitled, yet again, a systematic review of metformin monotherapy and dual therapy with an SGLT2 inhibitor in the treatment of type 2 diabetes. It was published in Diabetes Research and Clinical Practice, October of 2017. And Ken, I can't tell if this came out of China or not. So maybe you could, maybe you got that information.
This one didn't, but the next one did.
Okay, so this is the SGLT2 inhibitors increase urinary glucose excretion by decreasing glucose reabsorption in the renal tubules. It's an effect that's independent of insulin and independent of the degree of insulin resistance. So basically, you inhibit this enzyme, this SGLT2, 90% of which lives in the renal tubules. That is responsible for reabsorbing glucose. If you inhibit it, glucose ends up in the urine. Pretty simple concept. So they set out to ask the question whether a combined therapy with these newer agents and metformin is better than monotherapy with metformin alone in terms of A1C and body weight. So they ultimately identified 7 articles, pretty large number of participants, about 4,000, just south of 4,000, these 7 articles. And in all of the studies, there was a significant decrease in the A1C, if we consider that to be an important outcome, and body weight when you have combined therapy versus with metformin and SGLT2 inhibitors versus metformin alone. The delta for the A1C decrease, again, they had a lot of data in their article, was about a 0.5%. So metformin, you get X, metformin plus SGLT2, you get X minus 0.5%. So basically, you're getting a 5% difference with regards to the effectiveness of A1C, if that's an important outcome. When they looked at the effect on weight loss, it was anywhere between 1.5 and 3 kilograms when you use combined therapy over metformin alone. And of course, they didn't talk about this, but the cost of these medications is pretty astronomical, about $500 a month when you go up to the goodrx.com. Now, I might say that there was one major study, and there's almost assuredly to be more studies that are looking at hard outcomes, not just what happens to the A1C, but hard outcomes with these SGLT2 inhibitors. And the EMPA-REGS trial came out in the New England Journal probably about 2 years-ish ago. In high-risk diabetic patients, it was add-on therapy versus add-on placebo, followed group of high-risk type 2 diabetic patients through for about 24 to 36 months, and they found decreased macrovascular events in those who were given the SGLT2 inhibitors. So what happened as a result of that, the ADA now has identified SGLT2 inhibitors as a preferred second-line agent after metformin in patients with established atherosclerotic cardiovascular disease. So in the olden days, read last year, they had no preference for a second-line agent. These SGLT2s are one of 2 classes of medications now that they give preferential recommendations for in high-risk diabetic patients with pre-established vascular disease. So in addition to that, of course, since we're getting these improved macrovascular outcomes, you're also seeing some improvement in weight and A1C, which is really what abstract number 11 was all about.
So here's a little tidbit to anybody who's listening. If you want to do a systematic review and meta-analysis, because I said you don't have to do some large trial, don't do it crappy. They searched PubMed only, one electronic database, PubMed, and there's good research that says if you just search PubMed, you're going to miss some stuff. And then they limited it to English only, and then they have a surrogate outcome of hemoglobin A1C. They reported no conflicts of interest, but it would have been nice to have gone back to the original articles that they included and said, did the original articles have conflicts of interest? Because this is how you can compound problems, is if you have a number of little studies with methodological flaws, or they have problems in it, or they have conflicts of interest. Just because you put them in the meat grinder doesn't get rid of these biases or conflicts of interest. So if you're going to do one, do a good one.
Hey, Ken, let me ask you this. That's actually an excellent point. After having done these types of events for podcasts and lectures and stuff for a number of years, I don't think I've ever seen, when I've looked at the methodology, that they incorporate a conflict of interest rating in the method section for meta-analyses and systematic reviews. I agree with you. Is that something that is out there? Is that something that people are ignoring? Is that something I'm just missing? I mean, what's your opinion on that?
So there's different ways to assess the literature for biases, and there's different tools that people can have, and they have names that go with them. And so there's the Cochrane tool, and there's other tools that you can use. And I can't remember specifically if they include the bias of conflict of interest in those tools, but I think it's really important if you're going to put these if you're going to put the studies together, it doesn't eliminate those types of biases. And so you really need to go back to the original literature and say, did the included studies have issues with them? And it's not just the issues of randomization and blinding and allocation and outcomes. You have to look at all the different biases, including conflicts of interest. And I always say, when I say bias, I'm talking about something that systematically pushes you away from the truth.
And that doesn't necessarily then include conflict of interest. I mean, but it could.
But it could, right? And so it's just something we should consider. And just because, and I always say this, at least I hope I always say this, is that just because it was funded, or just because there's some conflicts of interest, doesn't make the data wrong either. It's just one of the ways to assess the bias and put it through a filter and say, okay, how much weight do I give this? How much scrutiny am I going to put this to? How loud will my skeptical radar go off? That's all. It doesn't speak to whether it's true or not, just how closely I'm going to look at the data and how they've interpreted it.
Thank you.
No problem. But you've got abstract number 12, and thank goodness this is the trifecta. It's a systematic review and meta-analysis. It is from China, and it's about diabetes. Nicely done, Gary.
So it's by Wang et al. And the title of the article is Combination Therapy of Metformin plus DPP4 Inhibitor, Dipeptidyl Peptidase 4 Inhibitor versus Metformin plus sulfonylurea. So they were looking for articles essentially that looked at those combinations and compared them to each other in terms of harder outcomes. So the rest of the article is entitled, and their association with a decreased risk of cardiovascular disease in type 2 diabetics. It was in Medicine. Pretty high quality journal, September 2017, and it was from China, the PLA General Hospital and the Third Military Medical University. And as Ken, you pointed out, the authors themselves had no conflict of interest. The So I mentioned this was a meta-analysis looking at those two groups of patients. And I like this because they looked at all-cause mortality. One of my favorite outcomes, does the patient have a pulse or not? They also looked at morbidity as well, looking at cardiovascular morbidity. So they ultimately found 8 studies, 6 of which were retrospective and 2 of which were randomized controlled clinical trials. Again, average age, you might intuit, was kind of middle-aged to elderly, 50 to 67. Average year of follow-up was up to 1 to 4 years in these studies. And the depending on which study they looked at, the number of participants ranged between 108 and 450,000. Again, talk about a delta there. That was probably the biggest delta I've ever seen. The number of patients with pre-existing cardiovascular disease, however, wasn't specified. So among those on a combination of metformin plus this newer, one of these relatively newer class of agents, the DPP-4 inhibitors, and they looked at the relative risk of non-fatal cardiovascular events compared to metformin plus sulfonylurea, there was about a 30% decrease in risk of major cardiovascular events. Interestingly, the I-squared when they combined all 8 studies, was 88%. Ken, that's pretty high, isn't it?
That's pretty high.
That's pretty high. Thank you for confirming that.
That's
then they removed that one study. It's very interesting. They removed one study, redid the analysis, got roughly the same results, and the I-squared went from 88% down to 0. Which was kind of an interesting. I'm not sure I've seen that before. Maybe you can comment on this if you got any specific comments on that. Now, the relative risk of all-cause mortality, did the patient have a pulse or not at the end of the study, was also decreased with the combination of metformin plus the DPP-4 inhibitors versus metformin plus sulfonylureas. And depending on how you look at the statistics, it was anywhere between 42 and 28% decrease in all-cause mortality. And from my standpoint, it really is probably one of the hardest and most valid outcomes we can look at. It's not uncommon when I'm doing some CME work and we're talking about how do we measure outcomes, I ask how many people in the audience fill out death certificates. And almost everybody raises their hand. When I ask everybody how many people are 100% sure of what the patient died of when they filled out the death certificate, no hands go up. And so this idea of attribution of a specific, disease to mortality is much harder than figuring out whether the patient's dead or not. Regardless, cardiovascular, so all-cause mortality was also decreased in this particular study here. So it seems to me these are not being given a second, second preference for patients with established cardiovascular disease by the ADA. Certainly the SGLT2 inhibitors are, and the GLP-1 agonists are as well. I'm not sure what to do with this information, but it certainly suggests that at the very worst, sulfonylureas are really starting to find their way increasingly marginalized as some of these newer agents start to become available for us to use for type 2 diabetics.
Well, something that this meta-analysis points out, though, is, again, you have to look at the included studies. And they had 6 retrospective cohort studies and 2 RCTs, which you mentioned, right? And of those 8 studies, 800,000 patients. But if you looked at how much did the RCTs contribute, it was only about 3% of the whole population, 21,000 out of 800,000. So you know that those retrospective observational studies are going to way more be overrepresentative of the statistics. And so you're really looking at associations. And so just because it's a systematic review and meta-analysis doesn't mean that it's going to get you closer to the truth, because I would rather take a really good randomized control trial, multi-centered, double blind, all that kind of stuff, over something like this that's taking a bunch of apples, a whole bunch of apples, and 2 oranges, and putting them together and saying, what does this taste like? And so I'm really hesitant about using the systematic review in this way.
So Ken, point well taken. Should this study not have been done?
Well, whether or not it should not have been done, it's just how, again, it's cranked out of China. It's redundant. It doesn't ask the question we want answered necessarily, like you pointed out. Are you dead? Did you die? Looking at these things for cardiovascular disease and outcomes, I really want to know a good randomized control trials. If you don't have any good studies, why are you putting, a whole bunch of crappy studies with a couple of good studies potentially together to jack up your N, saying, oh, we had 800,000 people in the systematic review. Isn't it great? No, actually, it isn't that great of a study. So whether or not it gets published, I guess that would come to a journal editor to say, should we publish this? Is this relevant? Is this newsworthy? Is it move the needle in any way? Does it reinforce what we already know? And I read this one and I was left with, meh, like how is this helping me take care of patients? And I didn't find that it really did. That's it, though. That's all I've got on that. Or as I could
good summary. Good summary.
I could pull out my Forrest Gump and say, that's all I've got to say on that. Or, so Heather, but you, yeah, I might not be a smart man, Jenny. All right. So abstract number 13. Hey, you're back, Heather. Now
I am.
It's not a meta-analysis. Okay. But it is a systematic review. It is on diabetes, but I can confirm it is not of China.
It is not. It is from Massachusetts, and it's from pharmacists in theory. So this is Koppenrath et al., who are out of the Massachusetts College of Pharmacy and Health Sciences, with an article, dapagliflozin, which I can't even pronounce, saxagliptin fixed-dose tablets, a new sodium glucose cotransporter 2 and dipeptidyl peptidase 4 combination for the treatment of type 2 diabetes.
Very well done.
Wow, I could not have done that.
You're just trying to get something from me. Okay, so essentially these authors did a Medline search to see if there's anything out there. They found 3 studies. One had patients who were generally very well under good to moderate control. One had 40% of patients with an A1C greater than 9%. And overall they said, well, it seems safe, but we really don't have much safety and efficacy data. So it didn't help me at all, Ken. I'm sorry.
And it costs $500 for a 30-day supply.
A fool and his money are soon parted.
So, Ken, you do know that every new medication that gets approved by the FDA in the United States is always $500 a month.
Unless it's for curing hepatitis C. And then it's just add a couple zeros on the end of that, and it's $50,000. Or actually, that's not a month. It might be $5,000 a month. Because isn't it the total course is something between $60,000 and $80,000 for the course of the
just south of $100,000 for 3 months.
Yeah. Whoa! Yeah. But I do know that you have to have a cool name with an X or a Z or, well, I guess a Z in your case. But yeah, it has to have some cool name to start with.
Or J.
Or J. Okay, let's get off this. Gary 14. Okay, this better be the last article on diabetes. This has been one sweet month, I tell you. All right, and it's not in a systematic review, though, but it is a synopsis of the VA guidelines on the management of diabetes.
This, Ken,
poor Heather, she's falling apart here.
If there's one thing you should be extremely impressed about, if you read the guideline development and review process in this article, their management of conflict of interest just goes beyond the pale. So let me just read this. At the start of the development of this guideline, the CDG and other key points throughout, all members were required to submit disclosure statements for potential conflicts of interest in the previous 24 months. So that was number 1. Number 2, verbal affirmations of no conflicts were used during the meetings throughout the development process. Number 3, and I've never heard of this, the project team also used was also subject, so the people on the committee were also subject to, quote, random web-based surveillance.
Yikes. Do they have to pee in a jar too?
Gary, I think we're all surveilled in the U.S., aren't we?
Yeah, but this was, for example, they called it ProPublica. Are you familiar about that? Does that sound familiar?
I use ProPublica all the time. So whenever I get an article that my skeptical radar, Heather, you have no idea how deep the state goes, or how deep the state is. So yeah, when I get an article that I get this, ooga. Yes, that is my skeptical radar. I go to ProPublica and I put in the lead author or the author's name, and it'll tell you how much money they got from pharma in the last 2 years.
Really?
It's very interesting. Search yourself. You'll see how much you got for that nice residence luncheon that they had. They had to put somebody's name down. No? Are you? You don't take anything? Very well done.
I think I have an ancient umbrella that says Cardizem on it that my husband, a non-physician, got from somebody. but
second
it's
year
about
game.
20 years old. Yeah, I got to get rid of it. Yeah.
So he was at one of those meetings and walked around with a bag filling it full of pharmaceutical, paraphernalia 20 years ago.
As soon as we're done this, I'm looking both of you up. I'm looking both of you up on what's it called? ProPharmaca or ProPublica?
Yeah, pull this up one more time. It's called ProPublica.
ProPublica.
That's good. That's a good.
No, it's a great site to go to.
Until I read this article,
but
I didn't even know that existed. So that's a good.
I
good
really like this article. Actually, they really did a good job. And one of the first things they said under their guideline was their general approach was, quote, shared decision making to enhance patients' knowledge and satisfaction is recommended. Absolutely.
Yeah. So this is a great. So getting back to the original title of the article, it was by Colin PR et al. And it was a synopsis of the 2017 U.S. Department of Veterans Affairs, U.S. Department of Defense Clinical Practice Guideline, Management of Type 2 Diabetes, Annals of Internal Medicine, November 7th of 2017, basically. So it's just 6 months old or so. So basically what this was a description of not only the process, but also some of their key recommendations. And as Ken pointed out, their very first recommendation is, hey, engage in shared decision-making, incorporating the patient's values and some non-glycemic factors when interpreting the results of the hemoglobin A1C. This is not different, I might add, than the ADA's recommendation in how aggressive we should be with regards to A1C management. Perhaps being more stringent in those who are younger, those who can get an A1C down to 6 to 7 without significant risk for hypoglycemia. That is the biggest problem that we run into, of course, when we try to get more glycemic control. And the less the more disease burden you have, the less life expectancy, the more important comorbidities, established vascular complications, certainly patients' resources and the like. The more these go against the patient, essentially, the less aggressive we should be with regards to A1C targets. So what they said was set the A1C targets basically based upon the risk of complications and comorbidity, life expectancy, and patient preferences. So they came up with a couple of recommendations. This is, I think, what I'm going to boil this down to, is the patient has long life expectancy, relatively young, presumably, no major comorbid conditions, and mild or moderate, no or mild microvascular complications. They say an A1C of 6 to 7 is reasonable. And this is the new number for me. They say up to 8.5% is appropriate, if you read it closely, for most patients with type 2 diabetes. Those with multiple comorbidities or complications that shorten their life expectancy to less than 10 years or so. And so this is the first time I've actually seen an upper target of 8.5%. The ADA gives a tacit endorsement of an upper target of 8%. And this is based upon, we don't need to get into this, a lot of studies that have looked at this question as more versus less better with regards to A1C control. And there were 3 large trials that were done within the last 10 years that couldn't find any beneficial difference between better versus worse control, 7 versus 8 in the A1C. All they found was excessive harm, 3 to 5 times increase in the risk of hypoglycemia. A couple of other things, they say aggressive glycemic control is, quote, not recommended in hospitalized patients. So, basically given 140 to 180 is generally reasonable for those. And they go on to say in hospitalized patients essentially to use basal insulin and short-acting mealtime insulin or basal insulin with correction insulin in hospitalized patients not in the intensive care unit, essentially getting us away from a sliding scale. You check a blood sugar, and if it's X, you give them so many units. If it's Y, you give them so many units, getting away from sliding scale and being more prospective about the use of the insulin. So I thought the interesting thing for me anyways was the upper target of 8.5% is being recommended for really a lot of our diabetic patients, which is not too dissimilar from 8.0 with regards to the ADA.
I like their algorithm. I like the one-page algorithm that I could go through. Following that was, I think, well done to be able to put that together and follow through on it. But, Gary, while you were speaking, I muted my mic, I muted my camera, and I went to ProPublica Doctors for Dollars, and I searched up Heather. You know what I found? Nothing. There's not even a listing.
Search me real quick.
Nothing. Oh, I've searched you too. Don't.
And
believe me, I searched you and I found nothing. There's nothing under the two of you. And so that means that what you're getting from us, at least, is like pure, unconflicted interpretation of the literature, right? Nobody's paying us big dollars from big pharma to be talking about the literature this way. What you get is our interpretation of the literature. That's it. So, I was impressed. It didn't even mention was it Cardizam umbrella that your husband has?
Yeah, it's probably under his name.
Okay. Yeah. Anyway, so good job. I searched you. You're clean. You've got a clean record. If the government, if the government is, like Heather says, watching you, and Heather, it's not the government. It's Facebook. It's Facebook who's.
You're not paranoid.
Everything about you. No, neither am I.
You're not paranoid if they really are after you. That's all I've got to say.
All right. Abstract number 15. I really like this study. No, not because it's covering something other than diabetes. No, not because it's not a systematic review, but it asks a really important practical question. What's a normal temperature if you take it from an ear thermometer? What's normal?
So out of the mouths of babes, and I'm not referring to you as a babe, Ken. I'm so sorry.
Or I didn't know if you're referring to my age or the fact that I, need to get cleaned up here.
No. So this article was really interesting to me as I was preparing to teach first-year medical students, and we were talking about normal ranges for all kinds of things and why we've established normals the way that we have. So Levander et al. From Sweden published this in American Journal of Medical Science in October of 2017. It's entitled Variation in Normal Ear Temperature, short, sweet, to the point. And they say that really the definition for normal temperatures came out in the 1900s based on axillary temperatures and was never really standardized. So interesting. But they went through and did a pretty rigorous methodology of measuring a bunch of people in different age groups' temperature using a standard ear thermometer. And they found that men had different temperatures than women, except among the elderly, that menopausal status influenced temperatures, with premenopausal women having slightly higher temperatures than postmenopausal women. There was actually sometimes a difference from side to side, and then heart disease and age other than menopausal status also made a difference. So their conclusions were that, if you know somebody's baseline temperature, maybe we should actually be defining fever as 1 to 1.5 degrees Celsius greater than their normal temperature, accompanied by malaise. And you know what? That's what my elderly patients always tell me. They come in and they say, I know I'm only 98.9, but I'm normally 96.5. So this is real.
So that's
actually, no, this is one of the things I pulled out of this, because I have often had patients go, well, I run low. This is a fever for me, and so given in the clinical context of not feeling well, and even if it's quote unquote normal, it might be abnormal for them.
Yeah.
Now, did you notice that, what measurements did they use? What was that large thing with the letter C? Celsius.
I was looking at the name of the maker of the ear thermometer.
No, I was looking at, they measured it in Celsius, people. And then you go 99 point something. Centigrade, Celsius. I think centigrade's a bit older way of expressing it. Gary, geez, I don't want to say you're more mature than I am, but yeah, no, centigrade and centigrade and Celsius. Yeah. All right. Well, that's it for number 15, answering a very, very basic question. What's normal? And at the end of the day, it might be abnormal for them. I guess one of their Fitbits now or something like that, it'll have, biometric data. And then we'll just say, how is this 1 to 1.5 Celsius or centigrade higher than your normal?
So when somebody invents the tricorder, I really, really, really want one. That's all I can say.
What does a tricorder record?
Oh, you're not a Trekkie, are you? I'm
No.
sorry.
No.
Never mind.
Okay.
Oh my God, really? Oh, Heather, you just went way up in the polls, and Gary, dive, going down. Okay. Abstract number 17. Now, this was published in the Journal of It looked to see if a 3-day course of NSAIDs was non-inferior to a 3-day course of antibiotics for what? Like a sprained ankle? No, for an uncomplicated UTI. What do you think? Do NSAIDs work as well for a UTI as antibiotics?
No.
Yeah, duh.
But so So these authors are from Switzerland, Cronenberg et al. Symptomatic treatment of uncomplicated lower urinary tract infections in the ambulatory setting, a randomized double-blind trial. So their argument was that UTIs are one of the most common reasons that we prescribe antibiotics in outpatient settings, that there's concerns about increasing antibiotic resistance and all of these other things. And hey, if we could push fluids, give them symptomatic treatment, could we just push through it and not to have to give them antibiotics? And no. So
come on, tough it out there, suck it up, Buttercup. I mean, sure, it causes inflammation, but it's because of an infection.
Well, but we do that with ears, right?
What we do what with ears?
They're viral. They're not bacterial.
Yeah, and what do we do with colds? We give them all antibiotics. Couldn't we have targeted something else besides bladder infections for stewardship of antibiotics? Okay, back off, Ken. Sit down, Heather. It's all yours.
I mean, we've kind of blown the whole take-home message here, but I can go over just a little bit of this. Of course, this study was done primarily in women age 18 to 70. I'm not sure that a 70-year-old woman with a UTI has truly got an uncomplicated infection. They had good randomization and concealment. They used the women who were given NSAIDs got fosfomycin rescue at day 3 if they continued to have symptoms. So they didn't just strand them and leave them out there. But they found that data from both day 3 and day 7 favored antibiotics, and also that there was less rescue medication use, of course, in the antibiotic group. The hazard ratio was 1.64 regarding resolution of symptoms, and the hazard ratio was 10.06 for probability of using rescue medications if you used an NSAID. So please, please, please give your women with UTIs antibiotics.
Now, I'm just going to bounce this off the two of you. When you have a woman comes in and she looks you right in the eye, like really right in the eye, and go, I've had a bladder infection before. I've got a bladder infection now. Do you need any confirmatory data? Or do you go, yes, you have a bladder infection?
No, so I believe them. The question is, am I worried that they might have a resistant organism? Okay. Or something else that makes it complicated. But no, women who've had bladder infections, especially if you get enough history to exclude other vaginal causes of symptoms, they've got a bladder infection.
They've got a bladder, the feet are dancing on the floor. They're up and down every 5 minutes from the appointment to use the facilities. I mean, yeah, they don't have a fever. This is not a complicated thing. It's like, yep, I gotta go. It's a bladder infection.
Yeah, no, I agree. And I think there's evidence to support that also.
Yeah. There is something called interstitial cystitis, but this is somebody who comes in with recurrent symptoms, not somebody who's got a one-off UTI. Yep.
Yeah. Abstract number 8. Now, 18. Tell us about the 4. I don't know. Why couldn't it have been 5? Could you make up one more point for the European guidelines? Could you just throw one out there? But apparently they only have 4 main changes to the European guidelines for the management of herpes. Add one more. While you're doing this, just think of one more. We'll make a recommendation.
Okay. I'll look at my notes here and see if I can come up with it. But this was...
you do the 4. You do the 4, and Gary and I will think of one more. How's that?
Okay. Well,
Gary, you got this? You on this?
I'm ready. I'm
okay.
I'm paying attention this time.
Yeah, you go ahead, Heather. Yeah.
That worries me. I'm just saying. So Patel et al. An International Journal of STD and AIDS from December of 2017 published these updated guidelines. And what they said is that, 1, the gold standard for diagnosis of DNA detection, no more cell culture, because it's more sensitive and more specific. They also recommend, along with that, if you suspect genital herpes, you need to actually do the testing to confirm it. But they don't care if it, and they do care if it's a first-time episode, if it's type 1 or type 2. So they have recommendations that are meaty. They're not one-liners. This recommendation was that to use short course therapy for episodic therapy. So 2 days of acyclovir, 1 day of famciclovir, 3 days of valacyclovir. You could do 5 days, but that most people should do fine with these shorter courses. And they go into regimens pretty deeply. If you're going to do suppressive therapy, then you should use either acyclovir or valacyclovir, was the third recommendation. And the fourth recommendation was that the duration of treatment for an initial episode of HSV in a patient with HIV should be 10 days, which is longer than you necessarily have to do in patients without HIV. And some would actually advise, besides lengthening treatment, also doubling the doses. And they go into the specific dosing regimens as well. The other thing is that if you suspect HSV infection, start as early as possible to treat and base it on clinical suspicion alone, and you can go back and get some of the other testing. And then it goes, as I said, into quite a bit of depth about when you might still want to think about serology, although it's not recommended in most folks. Not to use benzocaine for symptomatic relief of pain, et cetera, et cetera.
Did they use the word zinc smear?
So that is related to the cell culture, and it is no longer recommended. Yeah.
That's the fifth right there. Do not use a zinc smear.
Yeah.
There we go. All right. Pulled that one right out of your memory. All right. So, do you want to take a break now and carry on? Do you want to get up and stretch? Okay. Yeah. Get
Just
up and
for a
stretch.
second.
Or how are we for time?
We're good. We're at 3:20 now. So we got an hour.
What time you want to come back?
5 minutes?
All right.
Yeah. Okay. See you in 5. More Grey Goose. Your speakers, I think your mic is muted.
Sorry, I said no, it's straight gin.
Oh, okay.
Here, I'm not sure if this will work. I was gonna see if I could actually pull up.
Yeah.
So I don't know. Can you see that?
Mm-hmm.
That was the night sky when we went to Isla Mujeres. Highly recommended.
Wow.
It's beautiful. Yeah. Who knows what else I'm doing here? Anyway. Gary's not the only. I'll wait till I guess. Gary's not the only one who goes to Spanish-speaking countries for fun.
Oh, you go to Mexico.
Yep.
Don't you have a place down there or what?
Yeah. Yep. And we went to see Cirque du Soleil. It's right at the resort, so that was kind of fun. Yeah.
Did you got a place in Florida and in Mexico?
Yeah.
Wow.
And my house here is a shambles.
Still, I'm impressed. Very impressed. Ken, you got a place in Switzerland, right? In the Caribbean.
Oh no. My I'm Monte Carlo. Come on, I've got that nice summer place in Iceland when the hot springs are out. Oh yeah, it's all the exotic places. Those special little pods that are in Thailand that sit on the ocean. Oh come on, it's a rusty fixer upper. All right, so 20 more to go. Or sorry, number 20 is where we're at. You good to go?
Yes. Yep.
Okay, Heather, abstract number 20 won the award for the most conflicts of interest this month, and it was a randomized control trial looking at an ADHD drug to treat binge eating.
Yes. So this was Hudson et al. In JAMA Psychiatry from September of 2017. Efficacy of lisdexamphetamine in adults with moderate to severe binge eating disorder, a randomized controlled trial. And so it was an international study done primarily in the U.S., but also Germany, Sweden, Spain, and Canada, something abbreviated that I didn't recognize.
Yeah, thanks. What was that? The bus? Boom, boom, going over me? I thought it would be Gary.
Be the last time. Come on.
I thought it was Gary that was going to get back at me for all the holiday heart jokes.
Nice. So I think this study speaks to the real problems with food that we have in America, that we have a binge eating disorder that doesn't otherwise meet criteria for some of the other eating disorders. So essentially what they did was they took a bunch of people, primarily women, who met criteria for this binge eating disorder. So they had to have had at least 3 binge eating days per week during this run-in period. They treated them with for 12 weeks, then took the responders and randomized them 1-to-1. That seems interesting, doesn't it? Hey, if you respond to this, will you keep responding to this? I mean, it was very strange. So anyway, in the people who responded during the run-in period and then received active drug rather than placebo in the continuation portion, they found that the time to relapse of binge eating disorders was longer than if you weren't receiving the medications. They found that to have more than 2 binge eating disorders per week times 2 week was considered to be the relapse as well as well-being score. They found that only 4% of treated individuals relapsed versus 32% in the placebo group. And for those people who were able to take it for 12 weeks to begin with, that they tolerated it pretty well with just some mild throat headaches. There was one woman who became pregnant while on the treatment, and that baby had multiple abnormalities and died. Incredibly tragic. They had done some things to protect against that. But again, really interesting methodology, manufactured sponsorship, and lots of conflicts of interest. So I'm not going to go to this as a first line drug. If I have somebody who is truly ruining their lives over these binge eating episodes, might I consider this? I might consider it if they didn't have other reasons not to.
Did they define binge eating?
Yes.
Yeah, they sure did. I mean, and it's an actual DSM diagnosis,
Okay.
and I apologize because I don't have it right
that's
here,
fine. I
but
just
they
didn't
had
know
to
if there was
have, moderate to severe binge eating disorder, at least 3 binge days per week, and a BMI of 18 to 45. And they couldn't have anorexia, bulimia, or psychiatric disorders comorbid. And I think it's eating beyond the amount to reach satiety is kind of the basics.
Unlike the rest of us.
And we throw out these terms like conflicts of interest, but when you actually look at the role of the funder or the sponsor, they were involved in the design of the study, the conduction of the study, the collection of the study, the management of the study, the analysis of the study, the interpretation of the data, preparation, review, and approval of the manuscript. Yeah. I mean, this is control, and they may have different agendas than you and I have with regards to patient care.
Yeah, absolutely.
All right, so abstract number 21. This is an observational study recommending that pregnant women eat a Mediterranean diet for the health of their child.
I thought this was my top 2 or 3 articles for the month. I just think
we haven't even talked about top articles yet.
I know we haven't. We've been late to that paradigm. But interesting hypothesis that first trimester nutrition in pregnant women will have an ultimate impact years later on the cardiometabolic profile of their offspring. I've never heard of that before, so this was new to me. Heather.
It's all about blaming mom. No, but there's I
am so glad I didn't say that.
I didn't say it.
It's what it feels like. There has also been some metabolics work that's actually looking at the contributions of dad in this too, but they think a lot of it might be mitochondrial. Anyway, just throwing that out there.
Well, thank you for clarifying that. So this is by Chetsi et al. In the journal Pediatric Obesity, August 2017, and the title of the article was Adherence to the Mediterranean Diet. Mediterranean diet's big now in lots and lots of studies. During pregnancy and offspring adiposity and cardiometabolic traits in childhood, the authors had no conflict of interest. So as I mentioned, this was really an interesting hypothesis looking at the connection between first trimester nutrition, cardiometabolic profiles a year later in the offspring. They looked at 2 cohorts of pregnant women. They had 997 mother-child pair from Massachusetts and compared them to 569 mother-child pairs from Greece. They subsequently measured the adherence in the first trimester to the Mediterranean diet. So just very briefly, Mediterranean diet has a high intake of olive oil, fruits, vegetables, legumes, nuts, whole grain products, and moderate intake of fish, and only small amounts of red and processed meat. So there's no one Mediterranean diet, but that's the general paradigm. Then what they did is they created a score for adherence to the Mediterranean diet between 0 and 9. 0 is minimal adherence, 9 is maximal adherence. And then they subsequently measured their offspring, the children's cardiometabolic profile, about 8 years later in the Massachusetts cohort and about 4 years later in Greece. So after controlling for multiple variables, what they found is that for each 3-point increase in this 9-point scale, the Mediterranean diet adherence score, regardless of which location they were in, whether they were in Greece or in Massachusetts, there was a decrease in BMI, lower waist circumference, lower skin fold thickness. They also noted a decrease in systolic and diastolic blood pressures. Now, these numbers weren't dramatic. I mean, we're talking about a BMI difference of 0.14 units, waist circumference 0.3 centimeters, but skin fold 0.6 centimeters. The systolic and diastolic blood pressures were 1 to 2 millimeters of mercury. Be that as it may, there was a trend in that direction. And certainly, I think one of the strengths of the studies is generalizability. So they used 2 different cohorts, 2 different countries, 2 different continents, basically, relatively large sample size, and it was a prospective design. So long story short, it brings up this hypothesis. And Heather, you started saying that this was blaming mom. I don't know that that's necessarily the way I'd look at this. I would look at this and saying, perhaps what gets eaten matters with regards to perhaps years later the profile of a woman's offspring.
Perhaps and if mom doesn't comply with the diet,
perhaps you should put down the shovel, Gary. Yeah, just walk away.
So what you're saying is I'm digging myself a tad bit deeper.
walk away from the shovel. No, here's what I put. I read into this. I don't want to make a mother feel guilty about anything that she's done during pregnancy, as long as she's, in it to have a really healthy child, great, and be supportive and advocate for a healthy diet. And if that healthy diet is a Mediterranean diet because she likes Mediterranean, great, super, happy to be supportive. If that super healthy diet is some other kind of diet that, foods that she likes, wonderful. But I don't want to, there's enough stress going on that I don't want to be like, they're eating the wrong food and they should have eaten the Mediterranean and I didn't get enough olive oil or something.
I ate soft serve ice cream with my Great Lakes whitefish, and oh my God, she's going to be born a freak.
Yeah, a super freak. She's a very freaky girl. Sorry. Just because I can't sing, Gary, doesn't mean I won't sing. But exactly. And maybe having that ice cream or whatever example you want is going to be great for someone's overall stress and whatever, right? I think it's complicated.
Yeah, I agree. I get that. To the author's credit, they actually did give a gradation of the score, right?
Yeah.
So nobody was perfect. Nobody was awful. Everybody's somewhere in between. I think the average score in one group was 3, and the other group was about 4 or so. So nobody's perfect on this, but
and they concluded that it was an observational study,
Sure.
So it supported the hypothesis, and that they correctly say that interventional trials would be needed, and then they gave this gentle recommendation saying it's reasonable to recommend a healthy diet, and one of those healthy diets are like the Mediterranean diet. So I think that's just great. Abstract number 22, though, we have a single center, unblinded RCT on pessaries to prevent preterm birth that goes against a systematic review and meta-analysis on this very topic.
Dun, dun, dun. So this is an Italian study by Sacconi et al. Published in JAMA in December 2017, effective cervical pessary on spontaneous preterm birth in women with singleton pregnancies and short cervical length, a randomized clinical trial. So preterm births come with all kinds of potential risks. It would be great if we could help to minimize those. We know that short cervical length, when measured at a very specific time in the pregnancy, appears to be the most potent predictor right now of who will have preterm birth. So they took these women who had singleton pregnancies, had never had a prior preterm pregnancy, which would also be a strong predictor, and place the pessaries at, I am blanking, at 18 to 23 weeks. 23 weeks, yeah, I apologize. And then they removed them by 34 weeks. So their primary outcome was spontaneous birth before 34 weeks, including premature rupture of membranes. And then they had a plethora of secondary outcomes that I'm actually not going to get into a whole lot, but really just focus more on the primary outcome. And they found that the hazard ratio was 0.36 with a confidence interval of 0.54 to 0.87 for the primary outcome of spontaneous birth. They found that the major adverse event was increase in vaginal discharge. Not a shock in anybody who's ever seen anybody who's used a pessary. And that was about 2-fold higher, but nothing that was a particular concern. So this actually looks, and I apologize, pessaries were removed at 37 weeks, not at 34 weeks. So this actually looks like a pretty promising study. They had 300 women. It was at a single center, so there may have been some additional coaching, a more heterogeneous population, yada, 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 all of those things. But I thought it was a really interesting study and would be a nice intervention to put in place if it held up in the greater set of literature, which I am being told it does not.
Any idea why it worked? What's the pathophysiological rationale?
So the idea is typically if you have increased pressure or contraction of the uterus, that helps to thin the cervix. So if you're mechanically helping just to bolster that.
Oh, got it.
So they had a difference of 8%. Is that right? Yeah, a difference of 8%. And they calculated a relative risk and then give a p-value of 0.04. with a wide confidence interval around that p-value. So I calculated the NNP, the number needed to pessary, and it was 13. Well, you guys are familiar with NNT and NNH, right? Number needed to treat, number needed. Yeah. So I just did the NNP, number needed to pessary of 13. But I also calculated something else, and this is called the fragility index. And I don't know if we've discussed this before on PCMA. So the fragility index is when you look at a study, you look at the control group and the experimental group. And we have, for years, arbitrarily set this p-value at 0.05. And what you can do is calculate how many people would have to switch groups from an event to a non-event in the control group, or in the experimental group from an event to a non-event, and how many people would have to change positions for the p-value to not be considered statistically significant. So the lower number of subjects that needed to change teams, I guess, switch sides or switch events, the more fragile the study is. And so I threw this into my handy-dandy fragility index calculator, and it's got a fragility index of 1. And so if one patient had actually not gone on to preterm, or if one patient had kept it past the 34 weeks and not gone into preterm, or vice versa, if any one of those things had happened, the study would no longer be statistically significant of 0.05. And there's a whole thing about that issue, but that's the fragility index. So this means that this study is very fragile with regards to the outcomes. And so given the existing literature on this didn't show benefit, and this single-centered unblinded study with wide confidence intervals and a fragility index of 1, I just remain skeptical of the results. It doesn't mean that they're not true. It just means that I'm skeptical that this will turn out to be the ultimate thing that we hope would prevent preterm birth.
Is there an online fragility index tool? This is an interesting concept.
Yeah, no, so it's a fragility index calculator. And so just type in fragility index calculator, it'll come up, and you just put in your control group and experimental group, numbers with the primary outcome and the total number of subjects, and numbers with the primary outcome in the experimental group and the total number in that group, and it calculates your fragility index for you. It's a great little tool when you're evaluating studies and then looking at p-values and saying, it just goes one step further for, like if just one patient had switched sides or switched outcomes, we wouldn't be talking about, oh, look, it showed a significant difference.
Isn't this just another way to look at the power of the study, though? It seems to me that smaller studies are going to be much more likely to be fragile than larger studies.
I guess it depends on your effect size too, though, what you're considering significant, right? Yeah. So it's really interesting to put some of your favorite studies into it. I mean, we've just been doing this recently with the NINS study back in 1995 for TPA and stroke, and it had a fragility index of 3. So if 3 patients had had a different outcome, it would have negated the statistical significance of that NINS study on TPA and stroke. So it too is a very fragile study. And considering the other literature that goes with it and around it, it just makes you think, yikes, not that strong of a study.
Yeah,
anyway, so that's just a little tip for, I always like to bring some nerdiness into every episode. And I thought, you know what, I'm going to talk about the fragility index this time. All right, so abstract number 24, third most conflict of interest study this month. And it's looking at a treatment for gout. Do you know that means there's a second most common? Because I've already talked about the first.
Yes.
Now you guys haven't talked about your favorite studies either. So maybe, Gary, you think about that while she's presenting this one. Your favorite study. And
I'm pretty sure that I have the number 2 and number 3 coming up here. So. Awesome. Okay, so Dalbeth et al. In Arthritis and Rheumatology from December 2017, effects of febuxostat in early gout, a randomized double-blind placebo-controlled study, and they compared the febuxostat versus placebo. The reason why I wanted to talk about this study is because before we had talked about whether or not it's worthwhile to do the genetic testing to see if a patient can take allopurinol or if they're at high risk for the adverse events. And febuxostat was one of the drugs that can't come up as potentially being the alternative for people who are at high risk. So this was had lots of conflicts of interest. It was funded. The by pharma. Pharma helped to write it, et cetera, et cetera. And it's not the greatest study beyond that either. One of the things that I did like about it was that in addition to just having a primary outcome that was related to uric acid levels, that they also looked at the patient-oriented outcome of gout flares as a secondary outcome. So would have been better if it had been primary, but at least they did have that in there. So, and they found that treatment with this medication for 24 months had no changes in X-ray findings for, I apologize, this one didn't use just the uric acid. It also used some different radiographic studies. So no change in X-ray, and MRI improved synovitis. I don't know that I care. The number of flares were the same in the first 12 months and then went down in the second 12 months of treatment. And the serum uric acid level dropped by about 2/3 with treatment with active drug. There were a few adverse events in both groups, primarily changes in LFTs, and there was one death in each group. So some limitations beyond the conflicts of interest. These were primarily postmenopausal women, or mostly obese white men, and so it's not particularly generalizable. Super expensive drug, and I'm not sure that I care at all about their primary outcome, which all had to do with these MRI things. And there's always some risk in looking at the secondary outcomes and deciding whether or not you would choose a drug. So,
I'm glad though that you picked it, because again, just because a study has conflicts of interest and stuff, and just because a study may not be well done, there's always some really good stuff to find out about it, especially if it's a topic area that we need to consider when prescribing. So sometimes it's, we need you to know this because this is maybe something we wouldn't recommend based on the fact that, it wasn't the strongest study. It's really expensive. Their primary outcome was no different. The secondary outcome was a surrogate marker, but to inform people, because if they just read the abstract and the conclusions, they go, hey, this seems reasonable. And so we need to pick these studies so we can inform the audience so that they know that. One other big major limitation, though, that I picked up, and I don't know if you said it, was that they lost more than 40% of the subjects before the end of the study. And if you're losing that many people, how do you know if the results really represent what those 40+% of people, what happened to them? And what happened if they had adverse events and no benefit? So again, if you see a big number, especially if the number of missing people exceeds the effect size, I'm concerned.
Yep, absolutely.
So abstract number 23, this is number 2 on conflicts of interest.
And you'll be shocked to know that it's actually the same primary author, Dalbeth et al., in the same journal, but from September of 2017. And this one is lesinurad, a selective uric acid reabsorption inhibitor, in combination with febuxostat in patients with tophaceous gout. And so their primary outcome was, did it actually decrease uric acid levels? Their second was resolution of tophi in tophaceous gout. So they found that there was a decrease in the uric acid level that seemed to be best for the higher dose of the lesinurad that they used. They found that there was no significant difference in resolution of tophi, but they talked about this decrease in the number of tophaceous targets or something, which I think is a bunch of bull. They found that gout flares were higher in the first month, and that there were also significantly more adverse events in the 2 drug treatment group, and that was primarily reversible changes in creatinine. So in conclusion, I think this was a study that looked at biochemical outcomes that documented increased adverse events with no change in what we would consider as powerful clinical outcomes. So I would not use this medication.
Gary, using this one?
No, I not at all. No, I'm I just by nature, I'm a bit of a skeptic. I know that you've already taken that phrase for your email moniker, so I can't actually do that. But these new medications, for the most part, they've got to be around for a long time before I'm going to really consider their use, because we've got so many other good options.
Well, abstract number 26 is from New Zealand, and so I'm not going to do a Scottish accent for that one. But it was published in the Canadian Medical Association journal, So I could bring out the Canadian. And they wanted to know if the annual administration of zoledronate lasted beyond 1 year.
Okay. So this is Gray et al. In the Canadian Medical Association Journal from September of 2017. Duration of anti-resorptive activity of zoledronate in postmenopausal women with osteopenia, a randomized controlled multi-dose trial. So we're doing infusions for osteopenia. What? So first of all, I think treatment of osteopenia rather than osteoporosis is somewhat controversial. And the guidelines talk about treating osteopenia only if you have significant increase of 10-year risk of hip or other major osteoporotic fractures using FRAX. So that's just one thing I wanted to put out there. But what they did was they went through and did an extended follow-up of an earlier study they had done of 160 late menopausal women with osteopenia who had gotten a dose of zoledronate that could have been 1, 2.5, or 5 milligrams or placebo. They had most of these women, 152 of them, that they could follow up for 3 more years after the conclusion of the initial study. And what they found was that particularly with the higher doses, that the DEXA scanning, the bone density scores, remained elevated in some cases for up to 5 years after the infusion. So they concluded that doing 1-year infusions does not seem to be necessary in this group. And I would also add that not every woman with osteopenia needs to get the medication at all.
Abstract number 28. Now, I know we're all familiar with using extracorporeal shock wave therapy like lithotripsy. Okay, kidney stones, get rid of them. I didn't know you could use this for MSK conditions. This was like, oh, I didn't know that. So Heather, thanks.
Well, this may be shocking to you, Ken. Sorry, I don't have anywhere to go with that joke.
What, that it came from China? Is that what you mean?
Yes.
And it wasn't an acupuncture study?
Well, I've learned not to pick acupuncture studies for you. So I've at least moved to a different modality for you to
That's
revile.
like taking the needle and touching a nerve.
Yes. Awesome. So this is Lee et al. In Medicine from September of 2017, effective extracorporeal shockwave therapy for treating patients with chronic rotator cuff tendonitis. And the question is, if you're doing this shockwave therapy, does it potentially promote tissue healing, neovascularization, reduce inflammation, blah, 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 all very touchy-feely and scientific sounding. So they took 84 patients aged 18 to 65 and randomized them to undergo 5 sessions, so a session every 3 days with this extracorporeal shockwave therapy or placebo, which was a probe that made the same noises and kind of looked the same, but didn't actually do anything. You could argue that that may not have been enough of a placebo. And they followed them for 4 and 8 weeks to look at changes in shoulder pain, and which they rated using one specific scale, and function using 2 different scales. They had a total of 7 patients withdraw at 4 weeks and 15 withdraw at 8 weeks. So that makes 22 of 84 patients. So that is not a good thing at all. But they said, yes. So, but their conclusions were that it actually was more effective in relieving pain and improving shoulder function. At 4 weeks, they saw that the treatment group, the intervention group, dropped from a baseline pain scale score of 6.8 and dropped. The difference between the 2 groups was about negative 1.6. And by week 8, there was a difference of nearly 4. For function, they also saw some differences in the scales, about 20% difference between the 2 groups at week 4. And my math skills are not so great, but a little bit higher than that, maybe 25% or so at week 8 on one scale, and then some about 20% to a 40% change on the other scale. So I think it would be interesting to see this study done in a different setting with a better placebo group with some longer term follow-up and a lower dropout rate. Let's redo the study. because I don't think we're ready to start prescribing this or doing this on a regular basis, even though I see a significant number of patients coming in with this all of the time. And so I think it's a big enough problem that it would be worth actually doing additional studies and not just throwing it out the door.
Any harm?
Some increase in pain initially after the sessions. That was transient.
Because my understanding of extracorporeal shockwave therapy is actually quite painful.
Yeah.
So,
and that's what gets to the "I don't buy it" statement from me, because of the inadequate sham group to have a placebo effect. So basically, it's unmasking the study, and it's no longer randomized. Because if you're in the group that's like, "Ow, that really hurts," you're going to more likely think that you're in the active treatment group than the thing that's humming but isn't doing anything. It's like, well, it's not doing anything. But if you're like, "Oh, that really hurt. That was a really deep treatment." And the way around that is either to get some sham device that actually causes some discomfort as well, or ask the patients afterwards, after the study's over, which group did you think you were in? So approach your physiotherapy department in your institution and see if you can get a resident signed up for this, and do it over a couple of years, and just make sure that, you know, that they do it blinded, and that they ask at the end of the study, did you think you were in the treatment group or did you think you were in the placebo group? And that can control for that, and see if you can find a better way to address a sham procedure in this.
I wonder if you could use capsaicin gel instead of
something
the
that hurts.
gel.
Yeah. No, just something that gives you discomfort, because there is evidence that the more uncomfortable or the more noxious or the more invasive or it hurts more, the stronger the placebo effect, right? That's why often we'll give things by injection. Oh, he's taking my pain seriously. He's giving me ketorolac. I am, so anyways, I don't buy it.
I have not had the same reaction to people to whom I give IM ceftriaxone, by the way. They are usually not pleased.
And well, it's a big volume actually, especially if you're, giving a gram or two. All right. So abstract number 29. If I follow the advice of cancer guidelines and cardiovascular guidelines, Gary, am I going to live longer?
It depends, Ken.
Yeah, I've trained you so well. Yes, it all depends.
So I like this. This is a great article. And again, the more I practice and the more I look at literature and stuff, the more I'm just increasingly convinced that how we live and what we eat and what we do with our bodies through space matters. With regards to lots and lots of different outcomes, and probably to degrees, 2 to 3 to 4 degrees greater than perhaps what we can do with other medical interventions. So this is yet another study looking at that general concept. The title was Concordance with Prevention Guidelines and Subsequent Cancer, Cardiovascular Disease, and Mortality, longitudinal study of older adults by Greenlee et al. In the American Journal of Epidemiology in November of 2017. So it's basically, to what degree does guideline concordance, and we'll talk about what that means in a minute, have an effect on major health events? So they prospectively examined that exact issue, the concordance with the guidelines, from both the American Cancer Society and the American Heart Association for disease prevention in relationship to cancer, cardiovascular disease, and mortality. What did they use? They had the cardiovascular health study enrollees, who are mostly non-Hispanic whites, median age of 72, range was pretty good though, 65 to 98, who had a baseline assessment between 89 and 96, and were disease-free at that time with regards to cancer and cardiovascular disease. Then they were followed for 15 years. So they had a good set, probably about 3,500 or so patients at baseline. Then what happened is that twice a year, they had collected BMI, blood pressure, cholesterol, glucose. They did a medication inventory, and then twice per year were pinged, if you want to call it that, for major health events and deaths. So what did they look at in terms of their baseline variables? First of all, they asked the question, to what degree was the cohort or individuals in the cohort active? And they looked at the physical activity recommendations of both the American Cancer Society and the American Heart Association, 150 minutes per week of moderate activity. So they had a dichotomous variable there. Then they looked at two dietary variables, which were slightly different between the American Cancer Society and the American Heart Association. The American Cancer Society has diet scores that are higher when you eat more fruits, more vegetables, consumption lower percentage of red meat, whole versus refined fine grains. So they were able to do a dietary score on the American Cancer Society recommendations between 0 and 10. 0 was unfavorable and 10 was ideal. So that was a second variable. So we had the exercise, we had the ACS dietary recommendations, and then secondarily they threw in the AHA, the American Heart Association dietary variables as well, limiting sweetened beverages, limiting sodium, maintaining a healthy weight. This isn't very dietary variables, but these are health variables, maintaining ideal blood pressure, cholesterol, et cetera, et cetera. And they had a 0 to 14 score. So 0 was unfavorable, 14 was favorable. Then they did a total guidelines concordance score by summing up all these components. So what did they find? They found that at the end of 15 years, only 2% of patients in the group of the 3,500 patients actually met ideal levels for all components, or 98% didn't. Then what they said was, what was the average score? So the average score on a 0 to 10 scale for the Cancer Society recommendations was 6.9 out of 10. The American Heart Association was 8.6 out of 14. So both of them were roughly just a little bit above median. Then what they did was they said, okay, highest versus lowest scores, concordance scores. So low concordance score, high concordance score. What was the difference with regards to outcomes with regards to cancer and cancer mortality and cardiovascular mortality? The bottom line statistic is there seemed to be a 50% associated decrease in risk for cancer and in risk for cardiovascular mortality when the higher scores, people with higher scores were compared to people with lower scores with regards to these variables. Then they went back and says, well, were these dependent upon cardiometabolic risks such as BMI, blood pressure, cholesterol, and fasting glucose, and they were independent of that. So long story short, there seems to be evidence now that there at least is an association between the adherence to these guidelines with regards to exercise, modifying risk factors and diets, and better outcomes after 15 years.
And Heather waits.
And it's all mom's fault.
Yeah.
The average age was 72, so way beyond childbearing age.
Yeah, but she'll always be your mother, Gary. Okay, my mom still shows
like
up.
20 years younger than I am.
No, but as in you always have a mother, right? And my mom, she still shows up at work sometimes and says, "Hey, Kenny Bear, I made these treats for you." And I'm like, "Not in front of the nurses, Mom."
I made these treats for you.
No nicknames in front of the nurses, all right? Yeah. So I think you pointed out, this does show an association, and it's evidence for the association. But it's not like these people were randomized. You will be randomized to follow the guidelines. Sure. You will be randomized not to follow the guidelines.
Those are impossible. Those are studies that are impossible.
No, I know. Yeah. But so you pointed out that it's an association, and then it's self-reported. But maybe the guidelines following is just a predictor of being more health conscious and more health literate. And so those people at the top end that are more health conscious, more literate, are more likely to follow these health recommendations than the people that aren't. And it's not following the guidelines per se, but it's overall how do they lead their life and how do they move through this environment that we have, like you expressed earlier.
Yeah, one of the interesting statistics I heard a number of years ago, and that is in the many studies where they have people who are randomized to a placebo, those who are adherent to the placebo have better outcomes than those who are non-adherent to the placebo. So it's essentially what you're talking about. Mm-hmm. This is a marker of perhaps just more attention to healthy life, healthy behavior.
Well, we're going to finish off May with number 30, and it's a paper looking at metered dose inhalers for COPD.
And I'm just going to throw out there that I was really disappointed that this study made Chest, which I think of as being a good journal. But this is an article by...
It's a pinnacle study. I mean, how could it not reach that height of Chest? I just make this stuff up on the fly, Heather, okay? This is all I got. Dad jokes. My goodness. Jokes. That's all I got.
That's okay. So Martinez et al. Writing in Chest from December of 2017, baseline symptom score impact on benefits of glycopyrrolate formoterol metered dose inhaler and COPD. And so this might be number 4 on your watch list. So this was a post hoc analysis of a drug-funded study that was also funded by the pharmaceutical company to see to follow up to the Pinnacle study. So the original Pinnacle studies reported that glycopyrrolate formoterol fixed dose MDI combinations were more effective than treating with monocomponent MDIs or tiotropium and COPD patients with moderate to severe airflow limitation. So what they were trying to do by going back through and reanalyzing the data from the 3,000 and change patients was if it mattered what their baseline symptom burden was. So the way they reported with their results was like they were trying to obscure and confuse you as much as possible so that you would be thrilled by their reported trend for improvement in change in quality of life score based on the thing. So essentially, they found that the response in an objective outcome of the change in FEV1 was similar at all health status levels using this particular instrument that they used, which was the CAT, my favorite part of the study, the CAT. And that as you had more issues with health status, that maybe using this drug instead of the component MDIs or tiotropium, that you did better on the quality of life. But no, it didn't really show that. So I'm not going to order this.
Ago?
I was trying to get the point across that these authors, 3 of which were employees of the company, were on a fishing trip, and they were fishing for some data in a post hoc analysis that could expand the publication of Pinnacle 1 and Pinnacle 2 that showed a disease-oriented outcome of FEV1.
Mm-hmm. Yep. For only $360 to $390 a month.
But for you today on GoodRx or whatever it is,
GoodRx.
GoodRx.com, we've got, if you've got a coupon, we've got a puffer. So, anyways.
Sad.
Spring has sprung, the grass is riz. I wonder where my PCMA is. Well, you've just had it. But make sure you listen to the essay because Heather's going to be covering, what is it, this non-alcoholic fatty liver disease and low-risk pathology diagnosis?
Yes, I was inspired by all of Gary's diabetes articles to talk about a different aspect of metabolic syndrome and.
Did you just say different aspect? Is this way you're getting at Gary again?
Emphasize it quite like that.
Gary, you've been taking the brunt of it today.
You know what? I've got big shoulders. I can handle it, man.
Oh, you can handle it. Yeah, and you've got your interview, and I'm not going to make you read out the Université Paris-Saclay Hospital Paul Brasseux. Yeah, we're not going to do that, okay? But it's on atrial fibrillation and cognitive factors.
It is.
Well, that's it. Hope you guys have a great spring, and I'll be back, or somebody will be back, next month for your PCMA.
Sounds great.
Take care. Well, this is it.
I know. I'm hitting the stop record button so I don't well up because I know you guys have heard the news. I heard the news just out of the blue. It was and I was like, but I'm having so much fun doing this.
We actually, it's interesting. We were out in Phoenix about 3 weeks ago for one of our CME courses. So Abel, Steve Brown, and myself. And John Hickner went over to Rick's house because he's got a house now in Paradise, not in Paradise Valley, but in. So he said he knew at that time, but he didn't want to break it to us, you know. So it just sounds like, you know, he's been able to keep the subscribers at about 300 per month.